to introduce you to Paulo Ballram. Dr. Paulo is a virtual friend. Actually, we've never met in person, just on video, and we talk a lot. Yeah, I had the honor to work with him in a very interesting project this year uh, for the IHI team in the United States. He lives in the U.S. and he's been working with pregnant women and child, and he's a physician, actually a former vascular surgeon, and he's now senior director at IHI. He's also a father and also a man who loves to meditate. So he had some ideas meditating, I think so. So he also plays accordion. So Paulo is full of uh, unusual qualities that, and he will share with us his great experience about using TWI for hospitals in Brazil for pregnant women on and how they developed a full virtual training process for that. So Paulo, I will pass the baton to you now, and I'm sure that we'll have a great session. So thank you. And
Thank you, Fred.
it's
Thank you so much for this opportunity. Can you hear me?
it's good. Yeah.
Yeah, good. Fred, I don't know if I told this to you, but this maternal mortality topic, it speaks to my heart because I'm a victim of maternal mortality. My mother died when I was 10 years old, and she was giving birth to her ninth child,
Hi.
and everything. Hey, Christina, how are you? And everything was fine. You know, she started the labor at night, and my father was a doctor, and he took her to the hospital, and she never came back. She died,
Oh,
and my sister died, and my father was left with 8 kids. My younger sister was 2 years old, and my oldest 14 years old, and we were 8 kids without a mother. So when i when I started doing this work for IHI, the Institute for Healthcare Improvement, I did because I don't want any family ever have the same experience that I had. So this topic speaks to my heart, and so I hope I can bring some light to this old problem with new ways to address this old problem. So without much ado, I will start my presentation here. And Fred, I hope it's gonna be more a conversation than a presentation. And please feel free to stop me, and so we can talk and discuss anything that you want. Okay.
Okay.
So this project, we decided to call it Mother's Hug because we want all the families still have something that I could not have anymore uh, many years ago when my mother died. And so the Institute for Healthcare Improvement, Albert Einstein Hospital, and the Merck for Mothers create this coalition to uh, start addressing this problem of maternal mortality using new tools and new ideas. And then that's when I, I got in contact with TWI, and especially job instruction, talking to Fred and exchange ideas with him. I decided to investigate a little bit deeper, and I thought it was I when I saw it, I said, "My goodness, this has a lot of potential in the healthcare system." So we decided to incorporate TWI in job instruction in this collaborative that is used to call abraço de mãe in Portuguese or mother's hug. So let me say something really quick about IHI. IHI is the Institute for Healthcare Improvement, and IHI turns 30 years old this year. And the picture that you see here is John Belwick. He's a pediatrician. And back then, he asked himself a question. Can you use the same tools that Toyota uses, Lean or other NASA, and apply to the healthcare system, translate these tools to have a healthcare system without that don't make mistakes, that it's prevents the mistakes, and it's perfectly designed to deliver the best care. So that's why he created IHI, and since then we've been involved in many collaborations worldwide. So IHI's mission is to improve health and healthcare worldwide. In our vision, is everyone has the best care in healthcare possible. And this photo is a photo from Brazil. We collaborate with 114 ICUs to decrease hospital-acquired infection in half in 3 years, and we achieved this result. It was amazing. All ICUs from SUS. That's a great example of the work that IHI does in Brazil. And our values are courage, love, equity, and trust. So I first defined the problem, and the problem in Brazil is that maternal mortality is still high. We have 60 deaths for 100,000 births alive. And this is still very high. We are not going to reach the millennium goal. That would be half of those deaths. And the biggest problem that I see here is the last 6 years, we could not reduce a single death. We still have 60, and we got stuck there. We are not improving. And the reason for that is, in my opinion, is the fact that we are not addressing, or we are not focusing on where the death happened most. Because I don't know if you guys knew this, but we have 3 delays that are responsible for maternal mortality. And the first one is the pregnant women. The women, they don't know that they're sick, and they don't look for a provider or for care. They don't know. So in the solution for this is to improve prenatal care and literacy among pregnant women. And because of that, 5% of the maternal deaths happened. The second delay is they know that they're sick, but they don't have access. And in the fact that they don't have access is responsible for 20% of the deaths. But the tragedy is that 75% of the deaths happen when they get in the hospital, but the healthcare professionals or the system of care don't recognize that they are deteriorating clinically. We don't know that she's sick, because just looking at her, we cannot tell that she's sick or not, or she's deteriorating clinically or not. So in our focus in Brazil should be this third moment, because in this third moment, 75% of the deaths happen inside the hospitals. And this is a big tragedy. So what are we trying to do here in bringing job instruction in TWI? It's one of the tools that we're using to address this problem. And this happened because the doctors, not because the doctors don't care and their nurses don't know what to do, but the fact is every system is perfectly designed to produce the results it gets. If you have 60 deaths per 100,000 birth alive is because we have a system that delivers these results. And and I don't believe that more training, more education is going to help us to solve this problem. We really have to redesign our system to improve the care for the patients and families. And IHI created in 2006 a methodology that it's called breakthrough series or collaboratives. And with this methodology that we've been improving year by year, we have to select a topic, and in this case was reduce maternal mortality in the third delay. We identify clinicians and improvement advisors and people that knows the model for improvement to help us to create a theory of change. And then we enroll participants, organizations that could be 10 to 200 organizations, and to participate in the endeavor to, in this case, reduce maternal mortality in 36% in 2 years. So all the organizations have put together and work in 2 years to reduce maternal mortality in the organization's participants. And we do this through learning sessions that now it's all virtual. And during these learning sessions, we teach the model for improvement and we teach the theory of change. And also we teach them how to run PDSA cycles, small tests of change. And they also talk together, creating an environment where all learn, all teach. And after 2, 3 years, we write all the results and disseminate these results to other organizations. So in this case, we use the model for improvement. The model for improvement has 3 questions. The first one is, what are we trying to accomplish? And in this case, was reduce maternal mortality by 30% in actually 24 months. We extended the project a little bit. The second question is, how we know that a change is an improvement? We select a family of measures. And the third one is, what change we can make that result in improvement? And we create at this moment one theory of change, and then we ask the teams to test all these changes in a small scale, sometimes one physician, one patient, and one nurse, to adapt these changes to their own environment. Using this methodology, we achieved so many good things. For example, in 12 organizations from the public sector, we reduced sepsis mortality in 60%, in hospital-acquired infections, 67% in the same organizations. The SUS project, the ICU projects, will reduce hospital-acquired infection in 63% in 116 public hospitals, and so on. In this project that I'm present, we're going to show that we reduce maternal mortality in where and how. So for us to do this and to offer all this online training, virtual training, the hospitals need to select what life-threatening condition they're going to work to reduce mortality. So 5 hospitals select sepsis, and 6 hospitals hemorrhage, and 8 hospitals eclampsia. And these are the 3 most common life-threatening conditions that kills our pregnant women in Brazil, and I think it's the same worldwide. So what we did, what he had in mind. So using Cato's setup model, we had to decide what it was the work standard in terms of service quality, the work standard for equipment and process, and also the work standard for people in the maternities that we are working with. And we conclude that the work standard for servicing quality should be zero maternal mortality avoidable, preventable due to a life-threatening condition. No maternity in Brazil should have any death, preventable death. So the second one's process. And when we decided the work standard, we said at least 90% of the women should be assessed using meals. I will explain what meals is. All the teams should ask 3 questions after assess the pregnant women with meals, and all of them should have a bundle of care if they decide that it's the case. And the third work standard is we really design who is going to do what. What is the role of the doctor? What's the role of the nurse and the nurse technician and etc. So after we decide what's the work standard, we need to transform protocols, guidelines that is very hard to be applied in an executable theory using TWI. That's when TWI came, because we need to collect all this information from many sources that is very confusing for the doctors, very confusing to the nurses, and create something simple enough for them to apply in 90% of the time, at least 90% of the time. So that's when TWI came and helped us so much. So I need to explain what is a bundle of care for those that don't know yet. The bundle of care was created by IHI, and it's a way to structure a structured way of improving the process of care and patient outcomes. It's a set of evidence-based practices, generally 3 to 5. And if you decide to apply the bundle, you have to apply all or nothing. We cannot stop in the middle. You need to, if you decide to apply the bundle, you need to apply everything. This is different from protocols, because protocols, you have to decide if you're gonna continue applying the elements or not. Fred, I'm hearing an echo. I don't know why.
You're getting an echo.
Yes.
Well, I don't know why as well. We are all closed with microphone.
All right. So that's fine. So, and here's an example of the bundle. Sepsis bundle has 1, 2, 3, 4, 5 elements. And when the teams decide to apply bundle sepsis, they have to apply everything. They have to measure the lactate. They have to withdraw blood to run blood cultures. They have to give antibiotic, crystalloid, and vasopressor in 1 hour. So it's all or nothing. That's the concept of a bundle. And in this case, since the way that the teams were measuring lactate, giving antibiotic, crystalloid, varied a lot, we decided to create a job breakdown sheet for each element of the bundle. And that's when TWI came. So the process we designed, in 95% of the pregnancy women should receive a standard care. And this care was, all of them should be assessed by using meals, modify early obstetric warning score. And if the meals is greater than 4, they have to ask 3 questions. Can be infection, is she bleeding, and could be eclampsia. If they answer yes, they have to apply the bundle. And the bundle is all or nothing. And after applying the bundle, they have to access the patient. And then they have to refer the patient after the application of the bundle. And So we create this work standard in actually a reliable care. So when the women arrives in the hospital, they should apply the meals. They have to ask the 3 questions. They have to decide if they're going to rescue these pregnant women. They have to reassess the women after applying the bundle, and finally refer the patient to the adequate place to continue the care. And here are some examples of the job breakdown sheet in the important steps, in key points, in the reasons. And we did this for example, to give antibiotic. We did this the same thing, how to measure lactate for patients with sepsis. And why we decide to do that? In improvement projects, we have to identify, quantify the problem, and set aims. And after identifying the problem, we have to identify the process causing results in low performance, and then develop change ideas and test ideas using PDSA cycles, and then we have to implement change and sustain the improvement. So we noticed in the model for improvement a gap between the test and the implementing. Teams were very comfortable on testing ideas in small scale, but when it comes to the implementing change, they were struggling. So that's when we decide to introduce job instruction between testing and implementing change. And this is very important because if you look at the Juran trilogy, Juran says all the systems has to plan the quality, improve the quality, and control the quality. And to control quality, we need to create a sustainable system to not go back to the same level of performance before the quality improvement initiatives. And that's when the TWI comes and helps so much. So, for example, every patient should receive oxytocin after the delivery. We noticed that just 60% of them were receiving oxytocin after delivery. So we create the job breakdown sheet in the important steps and key points and reasons. And every single step now was standardized, and we had a way to train all the healthcare professionals in the same way. So the job instruction training was 100% visual. And we decided to do this after the pandemic. And we offered for 15 participants the standard model to train in job instruction. 5 days, 2 hours, 15 participants. And we used the material that was created in 1946 and adapted by Mark Warren in the second edition in 2014. But our team and myself, we had to adapt everything to the healthcare system. The language is different. Instead of saying product, you have to say service. Instead of customer, we have to use patient. Instead of machines, you had to use equipment. And job, instead of job, you have to use process. And also, we change all the examples. For example, we use hand hygiene as an example, the meals process, or how to measure blood lost during vaginal birth. And that's an example. So this JI training was offered to 15 hospitals, and we transformed all the material in slides, and we had to translate to Portuguese. And then we create these intensive virtual sessions to create the job breakdown sheets. And here's the agenda was a standard agenda. We didn't do anything different. We just changed something here and there. And I showed this to you, the meals job breakdown sheet. What were the challenges teaching virtually? Some processes were very hard to teach. For example, quantifying blood loss. And it's a very detailed process. And you see the example in a public hospital in Brazil. And we are training them virtually how to measure, how to weigh the blood that the patient lost, etc. So it was a big challenge, but it was possible. So the learnings, we could not teach some process virtually. Many of the processes are feasible to teach virtually. The change are going to stick when you standardize using JI. Results were sustainable as I'm going to demonstrate. And it is 100% possible to offer JI training visually. And one message, the healthcare system needs job instruction. And videos were very helpful to teach and interact with the audience. So I'm going to show to you some results. I will start from the process measures. For example, the modified early obstetric warning score compliance increased from 78% to 98%. That means almost every single pregnant women were being accessed using meals from now on. In sepsis bundle compliance, teams increased from 40 to 87%. Prevention of hemorrhage increased to 60% to 76%. Even though our goal was 95%, the teams could not achieve 95% in all the bundles. But just improving some, you're gonna see the results soon. And to treat hemorrhage, the bundle compliance increased from 60% to 8%. So all this work in the job instruction training and the creation of the bundles and training the teams result in 36% of maternal mortality for all causes in these 19 hospitals. And when you look for life-threatening condition, the focus of our initiatives, the mortality reduced 56%. And I collected data from January 2018 to March 2021. And then I continue to collecting this data 6 months after the end of the collaborative. And I was very glad to see that the result was sustainable. And when you look at sepsis, we had a 77% reduction in deaths, and the results is sustainable. The same thing happened with hemorrhage. We had a reduction in 75%, and the results are sustainable. Also, the cause of death changed. Before the collaborative was, the main cause of death was sepsis, and we had 103 deaths comparing the period before the collaborative, and after the collaborative we had 68 deaths, and the cause of death changed along the time. So in conclusion, this methodology, especially the introduction of job instruction, is powerful, very powerful to reduce in-hospital maternal death from life-threatening conditions. Focusing on the third delay, it's very effective. TWI, especially job instruction, brought standardization in an effective, efficient way to train the teams and also create standard process. And job instruction needs to be adapted to the healthcare system. Fred, with you, I hope I could communicate well the main concepts here.
Hi, Paulo. Thank you. Amazing. Incredible presentation. I don't know if we have somebody who wants to. Well, we have Daniel asking if we. I think we have time for one question. Christina, is okay? Not pretty sure about that.
Yes, it's okay. It's okay. It's okay.
Yes. Daniel from Brazil asked about using job relations in order to facilitate job instructions adoption. What do you think about job relations, Paulo?
So I studied job relation a lot, and I think that's the next thing that I want to try is job relations. I haven't tried yet, but it's a good thing. Job methods, it's at least for a while, is out of question. I studied a lot job methods, and I don't think it's applied a lot to the healthcare system. But I agree, job relation, it's the next step.
Yeah, and I think that you're right. We should learn a lot about job relations. I don't think we have more time for questions because we are just 1 minute to go. I would like to thank you, Paulo, for your amazing work and your amazing presentation. I'm really impressed. I was telling everyone that, well, this is amazing. We must show this here because it's a piece of work that everyone should try to introduce and reproduce. And you're right. Healthcare need jobs instructions and need TWI. We need it. It's very helpful, and you can say, and you prove it is saving lives. So thank you very much for your participation, and hope we can meet quite soon in the future. Hope you're coming to Brazil someday, so maybe we can meet.
For sure.
Bye,
Fred.
Bye, everyone. Thank you for your participation.